Okay, so we ended the last video after an hour of talking about the evaluation and management section. So what I want to do this video is to actually look up some codes in the evaluation and management section based on short scenarios so that we can kind of get our feet wet on how to use this section. The first thing that I didn't have time on that really long video yesterday, I'm sorry. I didn't really have a good chance to now that we know our components, now that we know some codes require 3 of 3 components and some require 2 of 3 components, I did not have time to play around with the components to kind of see how you mix and match them. So if you'll go to your established patient, there's 5 codes in here, starts with 99211 all the way to 99215. And I'm going to throw out some different combinations of components so that we can get a feel for how you plug in that information before we actually get into some of the examples that I want to do. So, first scenario, let's say that you have a date of service with documentation that supports expanded problem-focused history, detailed examination, and moderate complexity of medical decision-making. So we have history that's expanded problem, we have exam that is detailed, and we have moderate complexity that is detailed. So 99213 is our expanded problem history. 99214 is our detailed examination and medical decision making that's moderate. Because established patient only has to meet 2 out of 3 components, and we have met our medical decision making as a component, you would be able to code 99214 for that visit, even though your history level is lower than what you need. This would be a detailed history, but you're only meeting 2 out of 3 components. So with 99214, you are meeting your exam component and your medical decision-making component. Now, if we go to, let's do the same thing here under our new patient. Now, new patients have to meet 3 out of 3. So let's do the same thing. So we have expanded problem-focused history, and then a detailed examination, and a moderate medical decision-making. So for a new patient, those 3 components are spread between 3 different codes. So if you have to meet 3 out of 3 components, if you were to pick the moderate complexity of your 99214, you would not have enough examination or enough history to claim that code. Because remember, we only have an expanded problem history, and this one requires comprehensive. And we only have a detailed examination, and this code 99204 requires comprehensive examination. So medical decision-making of modern, we cannot pick this code. So let's go to the next one down. We know we have a detailed examination, so let's look at this one. Detailed history, we do not have that. We only have expanded problem history. Detailed examination, we do have that one. We're good to go with that. Medical decision making of low complexity. Well, if we have a high complexity or a moderate complexity, then we certainly have a low complexity. So for code 99203, we actually do have 2 of these 3 components, but a new patient requires 3 of the 3 components, so we still cannot claim the code. So let's turn the page and go backwards again. This is what's very frustrating to most coders because you want to give them, as high a level of service as you can. So let's look at 99202. Expanded problem-focused history. Well, we know we have that. That's part of our scenario. Expanded problem-focused exam. Well, if we have a detailed exam, which is the next level up, then we would have an expanded problem-focused exam. So we have that one too. Straightforward medical decision-making. Again, if we have a moderate level, which is actually as much as a level 4, then we certainly have it for a level 2, or we certainly have straightforward. So for that scenario, we would have to claim the 99202 and just have a whole lot of documentation to support the examination and the medical decision making. So that scenario is why I stress that as you guys matriculate into your coding jobs, if you're assigning levels or educating your providers on good documentation, how to support their level of service that they feel like they have given to their patient, make sure the medical decision making is strong or is supportive of what was actually done. Okay, so that's what I didn't quite get to. Hopefully through some of these examples tonight, we'll see a little bit of that. I'm not sure if we will. So here's one that I just wrote out big enough because I'm going to be talking a lot of the scenarios, speaking them, and you won't see them. So I thought it would help to just have a couple of written out. I know it kind of looks elementary, but it is what it is. Okay, so this is a new patient. The history is expanded problem focus. The exam is expanded problem focus. And the medical decision making is straightforward. So it's new patient. New patient's where we're going to go first. So this is how I always begin. I start with what my patient status is. So I've got my new patient here. 99201 is problem focused, and I have more than that. 99202 is your expanded problem focused history, so I'm meeting that, so I'm going to keep moving on there, and we just did this one. I have expanded problem with examination, which we have, and I have straightforward. So based on this, we would again choose code 99202. And I did not plan that with my example before. That just kind of came out of my head. Let's do another one. We have a 10-year-old established patient. First thing I'm going to do, get to my established patient. Find where I'm at. Let me put that up here. So we have a problem-focused history, expanded problem-focused exam, medical decision-making is low, diagnosis is the flu. Very pertinent to these days. Okay, so I'm just going to start. This is not a nurse visit, so I'm going to ignore that one. I'm going to look here at 99212. So I have a problem-focused history. That one sure does have a problem-focused history. I'm going to look for my exam, expanded problem-focused exam. Well, 99212 doesn't have that. So I'm only meeting 2 out of 3. So I'm going to keep going and see what I can build on. So my 99213 has my expanded problem-focused exam. So I'm good to go there. If I can meet my medical decision-making, then I can pick this level. So my medical decision-making is low. So I do have 2 out of 3 components for this level. Because it's an established patient, I can drop one of them. I am including my medical decision-making. Again, the medical decision-making, that's not a rule or a guideline written down hard in stone. It's just a good rule of thumb for a best practice of how you would determine your levels of service. To always, the most critical part of a office visit is one, you have to have a patient, and two, you have to have a doctor that renders a diagnosis. And that rendering of the diagnosis is that medical decision making. So I just think it's a good rule of thumb. You don't have to take it, that you're not going to be tested on it on the AAPC. I'm giving you that because that's a good best practice for the real world when you're coding. Okay, so 99213 was our answer. So now we're gonna just what I call drill, and I'm gonna give a very short scenario, and then we're gonna find it in the book. And we'll do that, we'll do a few of those. So this is gonna be an office visit for a new patient, level 4. So the first thing I'm going to do, find my office visits. So here's my office visits. New patient. Here's my new patient. And then I'm going to remember yesterday I talked about that last number can tell you what your level is. So I'm going to go to my level with the last digit of 4. I'm under new patient. So the answer would be 99204. Okay, let's get back to the front page. This is what I used to make the students do. We had a lot of fun doing this. Let's do an office visit, established patient, level 1. So I'm office, established, level 1. That's our nurse visit, 99211. Okay, let's do another one. Let's get back to the front page so that we really feel like we're drilling. Hospital inpatient service, initial, level 2. Hospital inpatient, initial, level 2. So first we have to find our inpatient hospital inpatient services. Then we have to find our initial hospital care, and then a level 2. So I'm going to look at my last digit. So this ends in 1, this ends in 2. So 99222 would be the answer. Okay, let's go back to the beginning. Let's do home visit, new patient, level 5. Home visit, new patient, level 5. So let's find our home. For now, I'm just kind of going page by page. This is how I would do if I were just learning just like you. Home visits. Still going. I'm getting closer. Home services. So that would be your home visits. And it was a new patient, level 5. So this is new patient. There's my established. This is home visit. New patient, level 5. So I'm going to follow it. 99345 is my home visit, new patient, level 5. Okay, one more. Let's get back to the front page so we're not cheating. Emergency department, level 3. Emergency department, level 3. So let's get over here. Find our emergency department. Emergency department. There isn't a new or established. Everybody's new to the emergency room, even if you go every night. So emergency department, level 3. 99283. Okay, so that kind of gets you a little familiar with stuff. So now I'm going to read you a scenario and let's see where we're going to go. So we've got an 89-year-old diabetic female goes to the emergency department. Let me get this back to where we're not cheating. Sorry. Not a very good. Let me try that again. 89-year-old diabetic female presented to the emergency department for evaluation of a painful left arm. She has an x-ray. It's determined that she has a fracture. And you may want to write this down. The doctor performs a detailed history, a detailed exam and moderate complexity for the medical decision making. So detailed history, detailed exam, moderate medical decision making. So let's see what code we're gonna pick up. Gotta get there first. So on emergency department, I'm looking for detailed history, detailed exam, moderate complexity. So this is problem focused, expanded. So I have detailed history here. I have detailed exam, and I have moderate complexity. So for that scenario, it would be 99284. Now let's take this scenario and change it around a little bit, because in the emergency room, we have to meet 3 out of 3 and everybody's new. So let's say we have a detailed history, a expanded problem-focused exam, and moderate complexity. Detailed history, problem-focused exam, and moderate medical complexity. Let's see what we would do. So here's our detailed history. Here's our expanded problem-focused exam. And here's our moderate medical complexity, or MDM. So because the exam was not detailed, it has to go down a level. So we would only be able to code the 99283, and we would end up having a little extra history with this. Okay? Let's do some more. Let me so I can read you these scenarios. I'm gonna get in some different areas of the CPT. So here is the first scenario. Let's get back to the first page because we don't know where we're gonna end up going. And I know you gotta have really good listening skills or have a pen and paper and jot this down as we're going. I don't know. I know it's kind of weird. Okay, so a patient is admitted with a head injury. On the initial visit, the physician observes that the patient is unconscious and is bleeding from the right ear. The physician spends 70 minutes treating the patient and coordinating care, during which time a comprehensive history and exam are obtained. What E&M? So what do we do with that? What do we know? So they are seen for an initial visit. They are observed for 70 minutes, coordinating care, and there's a comprehensive history and exam are obtained. So comprehensive history and comprehensive exam. So this is very much the type of open-ended scenario that you may see both on your board and in some of the textbook stuff. So out of that initial visit, that implies it starts with a patient is admitted for head injury. So that admitted and initial visit pretty much leads you to an initial hospital. So once we get here, they're being admitted to the hospital. They've got a comprehensive history and a comprehensive exam. Since the patient is bleeding from the ear and is unconscious, you can assume that that's pretty high acuity or risk of something being tremendously wrong with that patient. So they've only given us comprehensive history and comprehensive exam, but they gave us time. So if we look at these, the initial hospital with a comprehensive history and a comprehensive exam, if we look down here, it actually says typically 70 minutes are spent at the bedside. And the doc did give us that. He told us. He told us that the patient's unconscious, that he did a comprehensive history, which I don't necessarily know how if they're unconscious. He did a comprehensive exam, which he certainly could have done, and spent 70 minutes. So 99223 would be the accurate code for that. Another one. Let's start at the beginning again, so we're not cheating. Oh, I always start on the wrong page. Okay, a 6-year-old child is seen by the family physician for her annual checkup and immunizations. Her last encounter was a year ago. Okay, so that's telling us the kid, it's a kid. They're coming in for a routine preventive visit to get their shots. So I'm going to go to preventive, and I'm just going to take my time to get there because we don't want to miss it. We're just learning this part of the CPT, so it's okay to go page by page. Time is not of the essence right now. So I'm going to go till I find preventive medicine. You can also, this is where, as you're getting familiar, this is also where you could have gone to the front, found preventive, which I think is on the next page. Preventive, and then gone to the page number. You can do it that way too if you don't want to go by pages. I'm a little old school. I do page by page because I'm still scanning it as I'm going. So eventually I'll be imprinting the order of things in here. Some of the organ systems work better. They go from head to toe, so it's a little bit easier to navigate. These don't really have a rhyme or reason. So, 6-year-old established patient. She was just seen a year ago. So let's turn the page to established. Let's plug in the age. So this would be 99393. Plug in the age, late childhood, 6 through 11 years. And that would be your code. You don't do anything with the immunizations and any of that. We don't have the information on it. If you did have all that information, then we could go in the medicine section and start coding all of those things too and have administration codes and that kind of thing. But for right now, we're just paying the doctor for his time. So he provided a preventive visit to an established patient, age 6, 99393. Okay, let's go back to the beginning. Patient has severe chest pain, is admitted for observation. So that gives you a clue right there. A comprehensive history and exam are performed. Medical decision-making is moderate. So patient is admitted for observation. Here's our hospital observation. They're all new patients. We want admitted. I'm just reading. Patient is released the same day. That's what I was looking for. So we have someone, they have severe chest pain, admitted to observation, released the same day, comprehensive history, comprehensive exam, moderate medical decision making. So if the patient was admitted and stayed till the next day, we would be right here. But because they were admitted and released on the same day, we've got to go over here to this chunk of codes. Remember, observation, admitted and discharged the same day. So this is where we've got to plug in now our comprehensive history, comprehensive exam, and moderate medical decision making. So all of them look like they're pretty comprehensive exam and histories. So I'm just going to look at my medical decision making. This is straightforward, moderate, and high. So 99235 is going to be the accurate answer because they told us they were in observation, admitted, discharged, same day, comprehensive history and exam, moderate medical decision making. Okay, let's try another one. Got to get back to the right page. Okay, patient is seen in the emergency department after she burned her hand. An expanded problem-focused history and exam were performed. Medical decision-making was low. So we have emergency room, expanded problem-focused history and exam, and low medical decision-making. So I got to get to my emergency room. Emergency room, and then I just start looking, expanded problem-focused exam and history, and low medical decision-making. So 99282 appears to be the code when I plug it in. Expanded problem-focused history and exam and low complexity. I'm just making sure I told you what I actually found. I don't want to lie. Okay, let's do one more like this. So I'm just trying to get you a little bit comfortable with this area. This is evaluation management very much simplified. A actual date of service, you're going to have to add up your components for your history and your exam and your medical decision making. But this is at least getting us familiar with the codes. On the CPC board, there'll be 10 questions from every section of the CPT. The E&M section of the CPC board will have 10 questions. Probably 3 of those 10 questions, maybe just 2, you will have to actually determine the level of service. So count up. So you'd have to be familiar with the different components of the audit form that we went over. These tables help. I didn't cover these tables last night in the video either, but these tables somewhat break down that audit form that I gave you, and they tell you what levels have what amount of documentation needed. What these tables don't give you is for an exam you need 2 to 7 body areas or organ systems, something like that. So you might want to, and I have had students do this, you might want to I don't know if you have any, I don't know. This one here is probably good that you could write in how many you need of what for the medical decision making, but you may want to find an empty spot and maybe draw the tables or write history for expanded problem, you need 1. For detailed, you need 2 to 9. You need review systems, whatever that. You may want to jot some of those down. That is okay notes to have on the board. And so then when it comes to those 2 or 3 that you actually have to count up and determine your level of service, you would at least have some of those breakdowns already in your notes, and then you could just go and plug them in. Might be a little easier. Okay, so here we go. Last one, doing this. Subsequent hospital visit is required for a 58-year-old patient admitted with esophageal neoplasm. What E&M could be reported? So subsequent hospital, he's begun to spit up blood. So I'm going to tell you a good little cheat for this. So we're looking for a subsequent hospital visit. Patient's admitted for esophageal neoplasm who is now spitting up blood. So let's find our subsequent hospital. This is subsequent observation. We need subsequent hospital. Here's our subsequent hospital. We have 3 levels. And let me tell you how I generally figure out my levels. So patient's been admitted. You already have the first day out of the way. So the goal of everybody who's admitted to the hospital is to get to go home. The doctors want you to fix you when you go home and all of that. So your subsequent days, these 3 levels are what's claimed every day besides the day you're admitted and the day you're discharged. Because remember, these are per day codes. So how do you accurately, or even close to accurately, figure out if it's a level 1, 2, or 3? Because the history is all there. You're going to have tons of history. They've been put in the hospital. You're probably going to have tons of examination. So it kind of comes down to that medical decision making and the status of the patient at any given time. So how I like to see this level 1, 2, and 3 is with a level 1, if you're claiming a subsequent day with a level 1, the patient's probably doing pretty good. They may be going home pretty soon. So that's their step to being discharged. Level 2 would indicate that although the patient isn't necessarily critical or getting a lot worse, they're still having medication changes. They're still maybe having some tests run. There's still maybe something that just isn't quite right. They're stable, but it just isn't quite right. So there's still work to be done to get this patient to a level 1 to get them to head home. So your level 3 is if that patient is not doing well. They've gotten significantly worse. Maybe they've got moved to ICU. Maybe they have brand new symptoms coming up that are having additional resources and additional testing. So for this particular scenario, we have our esophageal neoplasm patient who is now spitting up blood. Well, that could be an acute hemorrhage. So in deciding these 3 levels, and you could put notes to what I've just said in these, 99233 would be the correct answer. Okay, so that's another little tidbit of something. Let's do a couple more. You're probably getting a little tired of hearing me at this point. Let's go back. This is a patient in the emergency department, has 103 fever and acute respiratory distress. Physicians unable to obtain a history or perform a comprehensive examination because the patient's condition is critical. MDM is high, medical decision making is high. So the patient is unconscious, can't get any kind of history on him, can to some extent do a comprehensive exam, but I think the doc's so concerned with stabilizing the patient, he isn't able to do that. So let's get to the emergency department and see what we're going to do with this patient. Okay, so we're at the emergency department. If a patient is so critical that you cannot get a history on them, then you can assume the highest level of history. I mean, they for all you know, they're eaten up with cancer. You have no history on this patient. Makes it very, very difficult to accurately diagnose and treat a patient if you know nothing about them. Examination. If the patient is critical enough that the documentation says, look, all I was trying to do was get him stabilized, you can assume that's a high level too. And then they've told you that it's a high complexity of medical decision making. So for this scenario, based on the information that we have, it's a 99285. Now, had that, because the doctor said the patient was in critical condition. So had the doctor given us time factor, we may have been able to take this and flipped it into critical care if we had a time factor, but he did not give us a time. So all we have is the 99285. So what's the tidbit to learn? If the patient's critical enough that they cannot tell you their history, they cannot tell you, or you are not able because of stabilizing the patient or other, maybe they're so combative, the doctors really and the nurses having a very difficult time to treat them, you can bump those because that makes that patient extremely high risk and very difficult to treat. Okay, let's do one more since we're talking about, oh no, I won't tell you what we're talking about because then you'd know where we're going, and I can't tell you where we're going because we're having fun here. Okay, patient is called to the intensive care unit to provide care for a patient who receives 2nd and 3rd degree burns. Patient is in respiratory distress and is suffering from severe dehydration, which is very, very, very critical for a burn patient. The physician provides support for 2 hours. Later that day, the physician returns and provides an additional hour of critical care support. So now we know time and we know area, so it's critical care. So what I do, forget my scribblings here, they gave us 2 hours, which is 120 minutes, and then they gave us an additional hour. So we have 160 minutes to account for the critical care time. So I'm going to go to critical care. And remember, critical care, I had said all you have to do is just worry about this block. If you know your time, all you have to do is plug in what's here. And then always remember that you don't unbundle stuff. So know these guidelines. So we have 180 minutes. I'm going to come down here, 99291. And 99292 times 4 gets me my 180 minutes. It's a range, so you can just plug in that range. I don't ever do a times 1. Anything times itself is itself. That's kind of redundant to me. But you would do your 99291 and then your add-on. Remember your add-on codes of 99292 times 4 to get that time. And that's another example of how we use add-on codes. It piggybacks on this parent code or this whole code. The piggyback goes on the back of a whole code. All right, so that was some examples. We didn't get into the little tiny specific areas. We kind of hit most of the areas that you're going to see at least once. Get in your textbook, do all of the exercises, and you can always message me or comment if you need answers. If there's anything that I can do while you're studying this week, let me know. These are the videos for this week. According to the syllabus, you'll have all of them now. And then next week, we are starting, what are we starting? Here's the syllabus. We are doing anesthesia, and then we're doing the surgery guidelines, which is very short. And it will be in the same video probably as skin. I'll probably do those together. So that will be next week. So we are on a plan. We finished our first week. And I'll see you in the next video.